Good afternoon, everybody. I'm going to be presenting on Delta hepatitis today. This is an abbreviated deck. As I mentioned to Catherine earlier, Dr. Tatiana Kushner and I gave a presentation in Scottsdale last week on Delta, much larger, really state-of-the-art deck that we'll share out. And of course, this deck can be shared widely. So welcome, and we're very happy that Delta hepatitis is getting so much attention these days. And this deck actually I used to present to the Division of Viral Hepatitis at the CDC a few weeks ago. That was the first time I've been invited to give a presentation to the CDC, so it was quite an honor. I had to do a compressed version, and that's what this is today, so we have time for our cases, but a much broader data set will be sent to you. I do have relationships with a couple of the companies in this space, including Iger and Gilead. Those are on my website. Delta, as you know, is the most severe form of viral hepatitis, both for acute and chronic disease, although acute disease usually results in viral clearance when you have co-infection or simultaneous infection, and I'll get to that in just a moment. The reason to test for Delta, of course, is that there is this extremely high risk of progression to cirrhosis, liver failure, death, and liver cancer on a very short timeline. It's usually within 5 to 15 years for these complications. Delta is not curable, just like hepatitis B is not curable, but it is controllable. Hepatitis C, of course, is curable, and hepatitis A does not result in chronic infection, but can present with acute disease. Let's see if I can get to the right control buttons here. Transmission is percutaneous, mucosal contact, infectious blood or body fluids, and it really depends on what geography you're in terms of transmission. Mongolia, one of the highest prevalence rates of Delta in the world, appears to be horizontal transmission through sharp exposure, potentially also medical devices. Pakistan, another super high place for Delta prevalence, appears to be more adult transmission through medical devices, including dental procedures. This can be asymptomatic, both in its acute or chronic presentation. And of course, the consequences we talked about include cirrhosis and liver failure. There doesn't appear to be much in terms of extrahepatic manifestations of Delta hepatitis. The clinical course is highlighted here over a relatively short time. You can have this acute infection, which we call co-infection. It's kind of an interesting word because it's the opposite of what we usually think of as co-infection in terms of long-term disease. Spontaneous clearance of both the Delta and hepatitis B can occur in the 90% range, but chronic disease, if it does occur, can be rapid, as we've described. If you have this chronic disease, of course, we talked about timeline here, risk for chronic hepatitis, cirrhosis, liver cancer out throughout 10 years, and you've got percentages that are here, which provides a lot of detail. This is from a recent review article from Meow and Journal of Infectious Disease. Really want to talk about testing. We all know how serious Delta is. It's really now a matter of knowing about what tests to do, what tests are good, what tests have little value, and that's what I would be giving you my scientific and editorial comments on. I don't know why that's going forward, but we'll try to get that stabilized. As you know, we expect the CDC to come out with a statement to check all adults for hepatitis B, including hepatitis B surface antigen, core antibody total, and surface antibody. If you have an acute presentation of viral hepatitis or acute presentation of liver disease, that's the role for core IgM. We've really had a lot of, I think, effect on LabCorp Quest and other labs to correct their hepatitis panels. Too many patients are getting an acute panel, and really you want a chronic panel. What we really want to emphasize is in a surface antigen positive patient, you want to be reflexing to Delta antibody. Now it says Delta antibody total on here, but really what we're talking about is an IgG test. And there's also Delta IgM, but I'm going to classify Delta IgM to you all and clinically as having no value. There's a side discussion we could have during the cases about that. Most labs, including Quest, offer Delta RNA by PCR. And they have both a qualitative test and a quantitative test. What I found out yesterday is that the qual and the quant, at least at Quest, is the same test. But the qual, they just don't give you a number. But quant, they will give you a number. So why not order the quantitative test? And I want to highlight that the qualitative test for RNA PCR should not be ordered. You really want to know a number. And once we have multiple treatments available, you'll be able to follow that number. Delta antigen, also offered by a number of labs, but in my opinion, has no clinical value and should not be ordered. And we're trying to get the labs, sorry, I got a little allergy today. We're trying to get the labs to put these less valued tests really in a secondary position so people don't order them. We have a survey we've done recently with Quest, and we found out people are ordering lots of qualitative PCR, lots of Delta IgM, which really have no clinical value in terms of patient management. So we're trying to prioritize testing and educate people just on the website when you're ordering those lab tests. This is an algorithm for management, surface antigen to Delta IgG, which might also be called total, but IgG is the test. And then depending on ALT, you're going to be doing your various workups, but really that Delta IgG test, if it's positive, you reflex a quantitative HDV RNA by PCR. And of course, like all liver patients, you're going to be staging those patients most likely with elastography. It says FibroScan on here, but now there's 5 different machines that can do elastography, APRI, FIB4, so you know the stage of the disease at the time you evaluate the patient and prospectively. This is an updated slide, even just from the last few days. We keep updating this as more and more information comes in. So it says HDV antibody total at the top. Again, that's an IgG test. IgM is also available through a variety of labs. Quantitative, qualitative are listed here. Delta antigens listed. And then CDC is doing Delta genotyping, which I've never ordered. And they also have a NAT test. And CDC is ramping up their test to really be a standard by which other labs can compare their performance characteristics. I've also been doing a survey with all the different companies, and the companies have been quite transparent about their test, their methodology and their performance characteristics. And I really realize now that the labs, and this is specifically LabCorp, who's developing their tests, AREP, which has full tests available, and Quest, which has full tests available, have done a great job in terms of test performance. So when you order these tests in terms of sensitivity and specificity, you can trust those results. The test is positive. It's a positive test, indicating either current disease or exposure. And of course, if you get a PCR that's positive, it's a quantitative test, you can trust those numbers. But there are some caveats about genotyping that we can talk about during the Q&A. I'm going to skip this slide. Currently, we have this multi-step process. There's a hidden slide, which I'm not going to show, about what would happen if we had rapid testing, point of care testing, RDT testing, how it really would speed up patient care. But right now, this is a multi-step process. What we're trying to do with the labs is to try to get reflex testing set up. AREP basically said it's likely they would do it. They committed to doing it. They just have to go through some operational details, or working with Quest to do reflex testing. Hopefully we will have a LabCorp to do reflex. It would be a double reflex. It would be surface antigen to Delta antibody. If Delta antibody is positive, it would go to PCR quant. That would really save all of us a lot of time in terms of our patient assessment. What happens when you have reflex testing? If you look in the far right, you're looking at standard testing. They only identified 2 Delta seropositive patients. These are RNA positive patients. And with reflex testing, they identified 32 in this London setting. So reflex testing really works. This is a real world setting that was published just a few years ago. There's a huge unmet need. We have this large population that's infected. Very few patients are screened for Delta. Typically, we quote 20%. Even when they're screened, the diagnosis rate is low because they're not linked back to care or negative tests. And then management, it's hard to talk about this disease when you don't have a therapy, but there's a lot of management steps we can do, including surveillance for progression, surveillance for liver cancer, surveillance for people in their immediate household or contacts that might have Delta. So there's much to do. There's many reasons to check for Delta short of treatment. And of course, the only treatment we have now is interferon, but that's going to change shortly. Whom to test? This has been confusing. We're really trying to harmonize this. You just test everybody, and how to test total, which is IgG testing, anti-HDV, and HDV RNA PCR. EASL will come out with a separate Delta guideline that's already written. It's undergoing review. We're trying to accelerate AASLD to come out with their new B guidelines and new Delta guidelines and include these recommendations to test all and then to advocate for reflex testing. So we have a ways to go. We'd like to harmonize this across all these different guidance agencies and organizations. So tests are not widely available, as we know very clearly through this ECHO project and work I've been doing with the Philadelphia team. I think it's Dr. Torgerson and Catherine to try to get LabCorp up and running. And LabCorp has been very wonderfully cooperative to get their tests going. We've set up a variety of different collaborations in the US and in France to make sure LabCorp is comfortable with their test performance. We really want the CDC to make a statement to test all adults for B, and then we build into that a reflex testing process. The problem with PCR testing is that we trust that PCR if the patient's genotype 1, but if there are other genotypes, and there's up through 8 genotypes, and now they have new names. Genotype 1 is Italiense, and they have all these different names depending on where the virus was identified, like Peru, Peruese. But we'd like to be able to make sure that the primers are going to be detecting all the different genotypes. And that is a step that's taking place with AREP right now. They're going to get primers, obtain primers that will look for all the different genotypes, and we'll be advocating AREP, Mayo, LabCorp, and other labs to do the same. So treatment right now, we talk about pegylated interferon, and that is the best option we have available. The maintained viral response rate with pegylated interferon, if you look after treatment for 1 year and you look out 5 years, is between 15 and 20%. That sounds pretty depressing, but sounds like hepatitis C in the old days when we had interferon and peg interferon and peg interferon ribavirin. We're stepping up, but in the next 2 years, we're going to have bulevirtide, and we hope lonafarnib, and maybe even peg interferon lambda in 3 years to treat and get to a much higher rate of maintained virologic response. Very complicated slide because Delta assessment is complicated right now. We'd like to really compress this down to a relatively simple algorithm, and that will take place over the next 3 to 5 years as we learn how to use these new medications either alone or together. I'm not going to go into great detail on this slide, but it's a little bit of an extrapolation, but it's important to be thinking about Delta and try to reduce the complexity. As we wrap up this presentation, I'd like to just highlight these 4 classes of drugs and where they work. Bulevirtide, which was formerly known as Mercledex, is an entry inhibitor that binds at the NTCP bile acid receptor that blocks uptake of virus. We have prenylation inhibitors, lonafarnib, which works on an enzyme system that's in the host called farnesyl N-transferase. By blocking that enzyme, you block this prenylation process, which doesn't allow or blocks the virus from packaging. That will be given with ritonavir because ritonavir boosts the level of drug in the body and decreasing dosing, which decreases side effects of lonafarnib. This nucleic acid polymer class, Replicor has been studied over the last 10 years. It's not clear how they're going to make it through the FDA and get through the class 3 or phase 3 studies to get to licensing, but there's a lot of data that this drug works. It is associated with liver enzyme flares, and those flares are rarely, or there's no clear reports of liver decompensation yet, but that may be a risk with this when it's more broadly used. PEG interferon lambda is used as being studied because there are lambda receptors in the liver, very few PEG interferon lambda receptors systemically, decreasing side effects. And of course, as you look across this, it's really going to be about combination therapy. Merclidec will be approved for maintenance therapy with a daily injection. Actually, the injection and side effects profile of bulevirtide is quite rare, changes bile acid levels, and you might have a very low level injection site reaction, but it is a chronic therapy. But there's data emerging about using bulevirtide with interferon. And of course, lonafarnib will be used with standard interferon or later lambda interferon. And the nucleic acid polymers are being used with nucleotide analogs such as tenofovir and also interferon therapy. So it's like what we're doing with all of our other viruses in this class. It's going to be combination therapy that will get us to control. Endpoints in these studies are interesting. Of course, you want to clear virus, but if you even reduce the virus by 2 logs and have ALT normalization, that's associated with better outcomes, lower risk of progression, cancer, cirrhosis, death, and maybe even liver cancer. Now, we would like, of course, virus negative. We're using this term maintain virologic response because we're not using the word cure for Delta. Since B is not curable, Delta is not currently considered curable. Response to pegylated interferon is highlighted here. I was giving you that 15 to 20% range. This is just giving you a reference that looks back over a variety of different studies. This is, of course, not optimal because pegylated interferon alpha, of course, has side effects to it. And also there's challenges of accessing PEG interferon. Pegintron, which was made by sharing, which is now made by Merck, as I believe, is not widely available, may not be available at all. Roche was talking about pulling their PEG off production or selling it to a generic company. I heard recently it went to a generic company, but still is available. I'll try to track down these rumors, but interferon's not being used widely, of course. This is bulevirtide or Hepcludex as we change our name familiarity. It's a 2 milligram dose given once daily, chronically. Very few side effects, fortunately. Injection site reaction, change in bile acid levels are really the only side effects that I discuss when I'm talking about this medications. And it really will be about combination therapy. I'm not going to go into this slide in great detail because of time, but you can see HDV RNA undetectable. That's fantastic news. 24 weeks on treatment and ALT normalization and combined response. I really look at the HDV RNA undetectable as my best endpoint because a lot of times you don't normalize ALT even in our regular hepatitis B patients because of fatty liver or alcohol, or maybe just ongoing intrahepatic immune viral interactions. But this just gives you a peek about what bulevirtide can do. This is giving you a peek at what bulevirtide can do when given with pegylated interferon. If you look at the far right column in terms of viral control at month 12, we've got 94% of patients who are HDV RNA undetectable or decreased by greater than 2 logs. So in my practice, bulevirtide becomes available. I'm going to be thinking about short-term treatment with pegylated interferon, 12 months. I'm still an expert. I guess that's because of my age and using interferon, but I've treated over 2,000 patients with PEG interferon. I know how to use it, know how to consent people to using it and how to follow those individuals, but it is work. So this just highlights immune modulators, prenylation inhibitors, the secretion inhibitors. Bulevirtide's not on here because I just covered that, but it just gives you a little bit more details about this and where they are in terms of phase trials. So in summary, HDV is the most severe form of both acute and chronic viral hepatitis. We think there's about 15 million people infected globally, but you'll see estimates up to 70 million people. But I think that's because of a selection bias. I really think you can believe that 15 to 20 million number. In the US, we're thinking somewhere between 60,000 and 150,000. Why those numbers are so variable is it's not a reportable disease. We don't have access to testing. Testing is only being done in 20% at most of hepatitis B patients. And because of lack of testing, we don't have good epi. We don't have good natural history data. But as long as you have hepatitis B and surface antigen, Delta can survive. That's why we're not using the word cure, but maintain virologic response. If we can cure B, we can have at least a functional cure for Delta hepatitis. And of course, we're using the word functional cure for B with surface antigen loss, maintain virologic response for Delta if HDV RNA is negative. So I think it's time to go to cases. I wanted to keep this short, but we've got some great slide decks we can share widely. And I really want to thank
any faxes.
The CDC. I want to thank CLDF, who worked with me and Dr. Kushner last week in Scottsdale to put together a much more expansive presentation. The colleagues at ARIP, the colleagues at Quest, colleagues at LabCorp, colleagues at Mayo, who've been very collaborative and communicative about testing and test performance. You're going to see a lot of this data flow out soon with review articles and surveys. Lots happening, and thank you for having me, and I look forward to the cases.
Great. Thank you so much, Dr. Gish. We did have a question come in the chat box. The question is, the reflex options sound great. Any timelines or support the labs need? Any negative feedback on those?
No real negative feedback. We spoke to ARIP this week, and they said, well, we want to do it. We just got to go through an internal process. So that was an incredibly short yes that we got to. Quest was a little bit more circumspect because they were talking about reimbursement. Apparently, there's some challenges for reimbursement for Quest with reflex testing because insurance companies don't want to pay for things. They always find ways to deny payment for things. But if it gets into the guidelines, it'll make it much easier to make sure the insurance companies pay for this. LabCorp needs to get set up and running, and then we'll advocate for reflex testing. But Laura Gillum and all the collaborators at LabCorp have been wonderful to work with. Xiling Fong in Los Angeles has a serum bank of his survey of Mongolian patients that he's using to collaborate with labs. Emmanuel Gordian in France is helping us a lot with conference calls. He's the best person in the world in terms of lab testing. So there's a lot going on. A lot of people saying yes, a lot of people wanting to make this work.
Thank you. We have another question in the chat box. Is anti-HDV protective against subsequent exposure?
That's a great question, but we know with hepatitis B, once you have hepatitis B, you cannot get infected with another genotype, another serotype, even though some patients get combination infections. Once you have Delta, it doesn't look like you can get a different Delta genotype, although it's not really been an experimental model that has that. If you clear Delta, I don't know of any cases or reports where that person's had a new infection with Delta. But it's a fantastic question, and I'm going to think about that a little bit more and get back to you if I find more information.
Any other questions? All right. Wonderful. Thanks so much, Dr. Gish, again.